Hello, PsychU community, and welcome to today's discussion about an initiative that integrated behavioral health care into primary care at a nurse-led clinic. This was described in an article called Using the Omaha System to Evaluate the Integration of Behavioral Health Services into Nurse-Led Primary Health Care, as published in the Journal of Community Nursing. Today's podcast is sponsored by Otsuka Pharmaceutical Development and Commercialization, Incorporated, and Lundbeck, LLC. My name is Christina Duvernay, a Senior Associate for Open Minds, and I am joined by Kent Alford. Kent, would you tell us about yourself?
Okay, thank you. First of all, my name is Kent Alford. As you already mentioned, I'm a nurse. I'm a nurse executive. I currently work at Prince George's Hospital, University of Maryland Capital Region Health. I serve as their systems director for behavioral health. We have 3 hospitals in our system, and we have an array of behavioral health services, including inpatient, outpatient, and substance abuse programs. We are integrated not just in an inpatient unit, but we are all throughout the hospital, including our consultation services. And now, as recently, now we're doing telemedicine services for the behavioral health system. My current roles is I'm the Behavioral Health Consortium Chair for the state of Maryland. That's a group of executives that come together monthly and literally talk about everything that impacts behavioral health. And as you can imagine, in the COVID-19 environment, we're now meeting weekly to make sure that we all are kind of on sync and staying in the same lane in terms of managing behavioral health patients. In addition, I also work as adjunct faculty at Catholic University. My first and primary passion in behavioral health is teaching. And we teach the new generation all of our tricks, but also giving them new things, learning new things from them, particularly with telemedicine and how we can continue to increase the platform for delivery of care with behavioral health services. And then lastly, I sit on the Lieutenant Governor's Task Force, the Maryland Hospital Association for Behavioral Health. As you know, the state of Maryland is very proactive in identifying behavioral health issues. And that task force, we look at problems that impact the delivery of behavioral health services with the Lieutenant Governor as a resource to eliminate those barriers. So that has really expanded my knowledge of statewide legislation and laws that are used to support and sometimes impede behavioral health services. And again, it is a privilege to sit on that committee with the Lieutenant Governor.
Well, let's set the stage for our listeners. Thanks to a grant, a nurse-led primary care clinic located in an underserved urban locale in the Midwest undertook an initiative to fold in behavioral health care. Nurse leaders used the Omaha System Taxonomy to document the effects of their integration effort, comparing calendar year 2018 with calendar year 2016. One result, a 900% increase in psychosocial issues identified among individuals seen at the clinic. So let me first ask, what is the Omaha System Taxonomy and what is its place in nursing?
Okay, so basically the Omaha System Taxonomy basically looks at the several holistic domains of a patient and the issues that they may experience, be it psychosocial, spiritual, all these things, the elements that a person would need to be assessed. That includes a comprehensive look at the behavioral health issues, but also any factors that might impact the behavioral health domain. It's an evidence-based tool, and it allows a clinician to really tease out and make assessments that will really be impactful in all domains of a person's life instead of one specific tool.
Thank you. And as we know, this clinic, to forward its integration efforts, had to make some significant staffing changes, which were allowed by the fact that they were funded by grant. Would you comment on where they had to make the changes?
Well, I know in reviewing the article, some of the things they had to look at was in terms of the scope of where they would be, because again, in African American communities, it had to be a primary care setting where African Americans resided. So they had to kind of look at the location. They used that based upon evidence that submitted that shared that African Americans do better in receiving behavioral health information in a system or place that they're familiar. So they made changes there to create the clinic in a space where African Americans resided. In addition, they looked at the people who were part of that team, including they added a nurse, two nurse practitioners, a registered nurse case manager, a nurse director, and several other folks that were used to look at not just the nurse and I guess a nurse practitioner, but the whole team of specialized nurses that would be able to assess and monitor a patient. So those changes were made. And then lastly, of course, they actually looked at the data to see where African Americans would actually benefit from the data they received, and then looking at that, targeting it and changing it the next year over to make sure that that population received benefit from the treatment.
Thank you. And so you mentioned the community in which the clinic was located. The clinic's leaders noted that stigma against mental health care ran strong in the community they served. Can you tell me, what role does integrated co-located behavioral care play in erasing or at least attenuating stigma?
So first of all, the education of the staff was crucial. In reading the article, the competencies of them understanding about the African American population, what was the source of their stigma, was in that. In fact, that was done at a pretty robust level to educate the staff. And then once the education about competencies, cultural competencies, were integrated, then they could go out and practice and assess the client. So education, cultural competencies that were done, what were given to the staff, and then after the cultural competencies, they looked at location that would be comfortable for African Americans where they live, so that they could carry out those assessments and interventions as indicated.
What were the main results that the clinic's leaders saw?
So the clinic leaders saw a lot. They actually, as you mentioned, they identified a lot of psychosocial issues in the study. Particularly, what jumped out in particularly reading the article, stress. As you can imagine, there were mostly Medicaid patients that jumped out, and uninsured. But as you know, they had many other stressors of surrounding that. So teaching them about stress management was one intervention that stuck out in the study, as well as the other intervention of giving them social work care, counseling, because a lot of them needed additional services like, the ability of being poor and impoverished, food, everything in terms of being able to deal with relationships. Those issues also jumped out. So they spent a lot of time dealing with social work, counseling, but stress was the biggest thing that they had to address. And teaching these clients interventions on relaxation, coping skills, helping them to problem solve, and then to remain in a place where they would proactively seek their care with some of the things identified and some of the interventions used to support that community.
So, what lessons are here for payers and for practice administrators?
So, when you talk about using this system, this Omaha model, first of all, the evidence-based tool, the Omaha tracking taxonomy system, was great. It assessed the patient in so many domains, and a lot of our payers, when we look at what we're targeting, we can't be limited in our scope of what we identify. For instance, if substance abuse is something that a lot of payers would focus on, you can't eliminate the homelessness, you can't eliminate the eating factors, you can't eliminate relationship things, but the Omaha system really did a good job in slicing through and assessing where was the need for these patients and what they needed, and these nurses were subject matter experts to get that. Secondly, when you look at the tool they used, one of the limitations in the study, of course, was the sample size. It didn't have a lot of people.
Mm,
However, um, this kind of identified us to say, well, you have places where Black folks go, like barbershops, beauty salons, schools, um, creating a space where they integrate that level of nurse managed clinic in the spaces where people operate will help decrease the stigma. Because African American, particularly African American men, push away from healthcare systems because of generational mistrust that has occurred. So we got to get their trust back, and winning their trust is visibility, education, cultural competence, um, even everything in terms of, and I didn't see this in the study per se, but how you engage African American populations, coming in with not a better than you attitude, but being very humble and going in your approach to understand
mm.
what is causing their concerns. And then, as this study mentioned, they got 900% increase of things that they've identified that African American populations were experiencing. And that data, we never got that data before because we didn't ask the right questions. So payers would really look at how they use this Omaha taxonomy system, adapting that model in our own African American populations, and then coming up with some solutions about how we can provide mental health services beyond just stress management or learning how to cope. What else can we give these populations beyond those things and really keep them in this primary care model so that they know we have those services available for them if they do become in crisis.
That's fascinating. Would you share your final thoughts on the article and your personal experience with integrated behavioral health care? The article stresses that nurses led the integration initiative. So let me ask you to comment on leadership and nurses. Why are nurses particularly well suited to drive initiatives like the one described in the article?
Well, being a nurse myself, our training is quite unique. Where the disease state in behavioral health patients is important, and that's where you have your psychiatrists that would be able to be the experts at managing disease state. Everything isn't acute in behavioral health, and nurses are trained from the beginning times in their schooling, even in graduate level programs. We're trained to look at the holistic approach of a patient. A patient is not just the disease. They are a sum of their experiences, their community, their responses to stress, their generational stressors, and nurses are educated early on in their degrees or careers to understand that, to assess that, and to provide interventions. And in this nurse managed clinic, I really appreciate the diversity they had in their staffing. You have registered nurses that were case managers. In their training, nurses are trained to kind of know where to find places where people don't have places to eat, or how to find someone a walker. Oh, you're having mental health issues, but you also have diabetes. So a nurse would be case manager, could connect them to a clinic that would address their diabetic issues. And again, that fits like hand in glove with the training that nurses receive to address the holistic part of the person. The advanced nurse practitioners who were used to support this clinic, again, have the ability to prescribe, treat, and diagnose. So once the assessments are made, a lot of times some of the limitations in doctor-led clinics was that the nurse would have to wait for a physician to make their assessment and then marry it to the nurse assessment. Where in this model, you already had a nurse practitioner that is now understanding the nursing components and now able to move forward with prescription and diagnosis and treatment. And that's a key point that I felt that was a really strong point for this clinic and probably why they had really positive outcomes. And so again, as the last question you asked me about my own experiences, I do work in a predominantly African American community. Prince George's Hospital is the DMV is usually considered the hub center for where a lot of underserved and minority populations go. My issue is that if we could have a clinic away from here, like a psychiatric urgent care, much like the model described in this article, how would that really affect our populations? Patients don't need to go to an inpatient unit to receive inpatient treatment. A lot of patients need just chronic stabilization, therapy, support, in this case, case management. Those are some things that we probably don't really do a good job at with the acute model, where a model like this one with the nurse managed clinic, you really get them connected to other services that will have them to have better outcomes. And I think reading this article, it really inspired me to want to develop a model like that here. After, of course, after we come from the COVID-19 crisis, I'm really looking at developing a psychiatric urgent care, much like described in this article, with the same evidence-based tools to see how we can support our behavioral health populations and minority populations. So I hope that answered your question. That was a long answer, but hope that answered what you asked me.
It was perfect. Ken, this has been a pleasure. Thank you again for your time. And of course, thank you to the PsyQ community for joining us. Have a great day.
Thank you. God bless.